As you said, my name is Christine Grundmeyer, and I am a registered nurse. I'm the administrator at Auxi Health in Northeast Iowa, and I'm the president of the board of the directors for the Alliance in Home Care, the Voice for Home Care in Iowa. I'm a member of the National Association for Home Care and Hospice, the largest home health trade association in the nation. Home health agencies are generally small businesses. The average home health agency revenue from Medicare, the primary payer of home health services, is under $1.5 million per year. Medicare standards for home health agencies address quality of care, financial reporting, and benefit administration. These requirements establish both broad parameters for operation and minute details on record keeping. Any divergence from these standards subject the home health agency to sanctions, including the potential for termination of participation in the Medicare program. For the purposes of the testimony, I've highlighted two areas of regulation under Medicare where plain English is an elusive element. In fact, if there was a plain English requirement applied to these areas by Medicare in the same manner that the substantive standards of the rules have been implemented, it might take 100 or more pages to define, redefine, clarify, and explain the meaning of plain English. OASIS. Let me speak to OASIS. OASIS is the manner by which home health agencies collect and report data used for outcome measures, public reporting of quality indicators, and case mix adjustment in the Medicare prospective pay system model. OASIS is a series of questions that are used to assess the patient at the start of care and periodically thereafter. While all the questions are included in the later quality of care analysis, only 25 are used in the PPS model to determine the case-specific amount of payment. 15 pages of data, 76 questions occupy a seasoned nurse for upwards of an hour and a half. From the single statutory mandate has sprung 36 pages of the Federal Registry on January 25, 1999, and a series of promulgated regulations. At that level, the rulemaking seems reasonable and simple. The payment model elements of OASIS bring an additional 45 pages of guidelines that overlap, sometimes repeat those interpretive guidelines in the quality of care realm. Home health agencies must have two sets of guidelines. One, which is this 800-page OASIS instruction manual, open at the same time to ensure the assessment and the payment standards are consistently met. While NAC and the Iowa Alliance in Home Care have continually reported confusion with the sets of complex and lengthy OASIS guidelines issued, the most telling sign of the complexity of the issuance is the issuance of hundreds of frequently asked questions, which comprise about 300 pages and 12 different categories. These are just the questions that people ask after they have the manual teaching them how to fill out the paperwork. NAC and the Iowa Association accredit CMS for its willingness to assist the home health agencies to achieve consistent compliance. However, if CMS is continuing to ask frequently asked questions nearly a decade after the promulgation of the OASIS rule, the message should be that the rule needs a plain English adjustment. It's inconceivable that a rule that requires this level of interpretation and clarification can result in proper application and performance in the real world. Now I'd like to speak to the Medicare patient notices. These are the two main notice requirements applicable to the Medicare home health agencies. The notices are the Home Health Advanced Beneficiary Notice and the Expedited Determination Notice. Under the guidelines established by CMS, there are times when both notices are to be presented to the Medicare beneficiaries at the same time. Similar to the OASIS requirements addressed above, the beneficiary notice requirement includes statutory and regulatory components along with extensive interpretive guidelines. After navigating hundreds of pages of instructions, home health agencies have the dizzying task of determining which notice is to be given, when it's to be provided, what information is to be included in the notice, what action the agency must take after the notice, and how to document the entire process. While the HHABN and the expedited determination notice requirements have been in place since 2001, home health agency staff still today report confusion on how the process is intended to work. What seems to be a simple matter on the surface, our services sought covered under Medicare, has become a compliance nightmare because of the endless exceptions, clarifications, overlapping instructions, new forms, and challenges to common sense. Plain English is a foreign concept in Medicare patient notice realm. Home health agencies support proper notices to patients in changes of coverage or services. However, the current notice structure is its own great roadblock to successful patient notice because of simplicity is sacrificed for a bureaucratic level of detail that nurses in home care have a great difficulty in managing while trying to provide essential care services. This concludes my formal remarks. I'm happy to answer any questions.